Mobilization of the fascia on the back. For diagnosis, the patient is prone with the head in a neutral position and the arms alongside the trunk. We examine mobility of soft tissues against bone in a cranial direction. Take up the slack and spring the barrier, and then compare the two sides. In our patient, mobility is restricted on the left. For treatment, the patient lies prone with his head turned to the side we will treat, in this case the left. The arm on the same side is fully extended, and so are the fingers of that hand. The toes on the foot of the same side press against the end of the table. The therapist fixes the fascia with one hand and mobilizes with the other. After the slack has been taken up, the patient inhales and we obtain release during exhalation. Breathe in, hold your breath, breathe out, relax, breathe in, hold your breath, and breathe out. This maneuver can be repeated 2 or 3 times. You can see that the therapist's hands are now further apart. If we wish to restore mobility of fascias and muscles in a caudal direction, we first compare mobility of soft tissues on either side in a neutral position and spring the barrier. The patient lies in the same position as the treatment in a cranial direction. The main difference is that we now begin with exhalation, creating increased resistance, while release is obtained during inhalation. Breathe out, breathe out. Breathe in, breathe in. Breathe out, and take a slow, deep breath in. This is repeated 2 or 3 times. You can see that now the therapist's hands move further apart. The most important muscle of the pelvic region is formed by the pelvic floor. It is formed mainly by levator ani and the coccygeus muscle. It has a twofold function. It's one of the walls of the abdominal cavity, playing an essential role in posture, and together with the diaphragm, it plays an important role in respiration. Its second role is to reinforce the anal sphincter in cooperation with the gluteus maximus. The pelvic floor is part of the deep stabilization system, and dysfunction is compensated by superficial muscles, which are not adapted for stabilization. The erector spinae, the quadratus lumborum, the psoas, the adductors, the hamstrings, the gluteal muscles, and even the diaphragm may then develop trigger points. A dysfunctional pelvic floor is compensated by superficial long muscles and frequently results in trigger points in the erector spinae at the level of the TL junction. These trigger points can cause the S reflex. This S reflex, i.e. Silverstolp's phenomenon, means that snapping palpation of the erector spinae trigger points at TL junction causes dorsiflexion of the pelvis. In typical cases, we also find a lateral gluteal pain point at the level of the coccyx. Diagnosis consists in direct palpation in the direction of the sacrotuberous ligament, at the side of and parallel with the coccyx in a cranial direction, where painful resistance of the coccygeus muscle is met. Symptoms caused by all these trigger points can usually be relieved promptly by gentle pressure on the coccygeus muscle. We can feel the resistance melting under our finger within a few seconds. However striking this immediate effect, the condition very easily recurs, and so the patient must be taught PIR of the pelvic floor to be practiced several times a day. The following procedure has proved effective. The patient first draws on his navel, contracting the transverse abdominis. Once he has mastered this, he lies on his side with his legs bent at the hips and knees and is told, "Now do the same with your navel and your anal region, as though trying to suck in a liquid, but do not pull your buttocks together. When drawing in the anal region, your buttocks must be completely relaxed." The patient holds the anal region and the navel drawn in for about 5 to 10 seconds and then relaxes completely for 20 seconds at least, even longer. In order to be sure that the patient has understood our instructions, we ask him to repeat the procedure. But now he first breathes in and then holds his nose, keeping the mouth shut. This maneuver produces negative pressure in the abdominal cavity, and the patient should really feel the exercise much better. If this is the case, we know that the patient has, indeed, moved and relaxed his pelvic floor. The patient repeats the exercise without holding his nose 2 or 3 times. We re-examine all the trigger points, as well as joint blockages. For example, SI blockage and trigger points in the erector spinae. All this should now be relieved if our diagnosis and treatment were correct. If this is so, we suggest that the patient performs this exercise several times a day in any position, lying, sitting, or even standing. We always stress that it is of crucial importance to exercise very slowly. This method is useless when done quickly. Examination and mobilization of the thoracic spine. We examine retroflexion, anteflexion, lateroflexion, and rotation. To examine retroflexion, the patient is seated with his hands clasped behind his neck. We grasp his arms below the elbows, lifting them and producing back bending. Palpating between the spinous processes with the other hand, we can feel how the spinous processes approach one another, and when we feel the first sign of resistance, we spring the joint. It's most important to move the patient in such a way that the vertex of the lordotic curve is at the level of the examiner's palpating finger. For mobilization, we prefer the patient to lie on his side. We now grasp his arms in a similar way and move him into lordosis with one hand, while with the other we fix the spinous process until we've taken up the slack. Press slightly against my arms and breathe in. Hold your breath, and now breathe out. Breathe out all you can, and relax. Once again, press against me and breathe in. Relax and breathe out. At the end of deep exhalation in a lordotic position, mobilization takes place due to the synkinetic contraction of the erector spinae. This is repeated 2 to 3 times. In rigid kyphotic thoracic spines and for self-treatment, it's most convenient to make use of the mobilizing force of the spinal erector trunci. The patient is seated with the thoracic spine straight, the legs in slight abduction, and his hands on his forehead resting on the wall. In this position, he breathes in, bringing the thoracic spine into slight kyphosis. This is followed by slow maximum exhalation facilitating lordosis. Breathe in as deep as possible into this area, and now relax and breathe out. It's useful to gently stimulate the skin of the affected segment in order to make clear to the patient the area into which he has to inhale as deep as possible. If this exercise is properly carried out, the patient should feel a slight pain between the shoulder blades as a result of the maximum contraction of the interscapular erector spinae. This is a very effective mobilization, but in patients with a hypermobile low thoracic spine, it results in exaggerated thoracolumbar lordosis instead of straightening the thoracic kyphosis. A slightly more difficult but more specific technique aimed at the mid-thoracic spine has the patient seated erect, the cervical spine straight, his arms abducted and flexed at the elbows, and the forearms pointing upwards. By external rotation of his arms, he straightens up his mid-thoracic spine. In this position, the patient exhales deeply and at the same time increases external rotation of his arms. This results in maximum contraction of the mid-thoracic erector trunci, which the patient feels as a slight pain. With maximum exhalation, the abdominal muscles contract and fix the thorax in the erect position, avoiding thoracolumbar hyperlordosis and posterior tilt of the thorax.